All right, let's scrub in and dive right into this explainer. Today we're exploring a precise 10-step procedural masterclass on the total laparoscopic hysterectomy. We are going to unpack a truly brilliant operative roadmap laid out by Dr. John Einartson and Dr. Yoko Suzuki from Brigham and Women's Hospital. So if you're looking to grasp exactly how this complex procedure is systematically broken down for maximum safety and efficiency, you are in the exact right place.
Here's our surgical roadmap for today. We're going to cover the shift to minimally invasive techniques, the big debate on keeping the cervix, prep and entry, dissection and vessel control, uterus removal and closure, and we'll wrap it all up with some expert post-op tips. Let's get to it.
So, Part 1. The minimally invasive shift. It's a true surgical evolution.
To really get why this matters, you gotta look at the sheer numbers. Hysterectomies are incredibly common. Just to put it in perspective, back in 2006, there were a whopping 570,000 cases performed in the US alone. But here's the crazy part. Despite having all this amazing minimally invasive tech, well over half of those were still done the old-fashioned way, via open abdominal surgery. You kind of have to ask yourself, why? Especially when we have much better options.
I mean, the evidence is pretty clear. The authors point out that vaginal and laparoscopic hysterectomies are absolutely associated with less blood loss, shorter hospital stays, getting back to your normal life way faster, and fewer abdominal wall infections. So the real takeaway here? Even with provider hurdles, like say inadequate training during residency, missing equipment, or even low reimbursement rates, the clinical benefits for the patient are just undeniable.
Moving on to Section 2. This is a big one. To keep the cervix, we're looking at total versus supracervical options.
Before making a single cut, there's a major debate. Do you remove the cervix, which makes it a total laparoscopic hysterectomy, or do you keep it? Now, keeping it might seem a bit easier technically, maybe even a little faster, but the long-term data, it paints a totally different picture. The authors found that almost a quarter, 22.8% to be exact, of patients who kept their cervix actually needed more surgery within 5 years for cyclical bleeding or pelvic pain. Plus, leaving that stump carries a 2.2% risk of cervical cancer down the road. It makes a really strong case for going total, especially if a patient has a history of abnormal paps or endometriosis.
All right, Section 3, preparation and abdominal entry. This is all about setting up for success.
You know, a smooth surgery really starts before the first incision. The authors actually stress simplifying your tools so the operating room doesn't get totally cluttered. We're talking just the essentials here. A standard 5mm 0-degree laparoscope, the harmonic scalpel for that really precise cutting and coagulation, a bipolar grasper, and, this is absolutely key, a specialized uterine manipulator like the Roomie. Keeping the tool set lean keeps the whole team dialed in and focused.
Let's walk through the first 3 steps. It kicks off with meticulous patient positioning. We're talking steep Trendelenburg, so tilted head down, with the legs secured in pneumo boots. After that, they insert that uterine manipulator we just talked about. It basically acts like a joystick to maneuver the uterus and clearly define the vaginal fornices. Then, the surgeon does a visual abdominal entry right at the belly button. This establishes pneumoperitoneum, safely pumping gas in to inflate the abdomen and create a nice, clear working space before adding the rest of the trocars.
Now, what's really fascinating here is seeing why that setup is absolutely crucial. You can actually see the edge of the KOH colpotometer ring pushing up from the inside. The surgeon has to visually confirm that it's placed right early on because it acts as this undeniable physical landmark. Seeing and feeling that ring is literally what prevents a devastating uteral injury later on when separating the uterus.
Section 4 brings us to dissection and vessel control. We're entering the most critical internal phases of the procedure.
Step 4 is where the real delicate work begins. The surgeon starts desiccating the utero-ovarian ligament. And the golden rule here, you gotta hug the ovary. Basically, you stay as incredibly close to it as possible, so you don't accidentally damage the pelvic sidewall. At the exact same time, you have to watch out for the parametrial venous plexus. You've really got to keep an eye on those winding, tortuous veins between the ovary and the round ligament, because trust me, they will bleed if you aren't paying attention.
Sliding right into Step 5, the harmonic scalpel is doing the heavy lifting. The surgeon is separating the anterior and posterior leaves of the broad ligament. The absolute key takeaway here is finding the exact anatomical plane where the peritoneum just separates easily with gentle nudging. It's all about working with the body's natural tissue boundaries to keep trauma to a minimum.
Next up, the dissection continues anteriorly to mobilize the bladder right off the lower uterine segment. And this is a super critical moment. The surgeon stays in that loose, airy tissue and intentionally stays high to avoid the fat. Why? Because down there, fat belongs to the bladder, and if you're seeing fat, you are getting way too close. Once it's mobilized, the surgeon can safely locate and actually feel that KOH ring we placed way back in step 2. That proves the bladder is safely pushed down and out of the danger zone.
Okay, step 6 is all about controlling the blood supply. Since human anatomy is so incredibly variable, the authors highly recommend a really methodical approach. First things first, you use the harmonic scalpel to carefully skeletonize the uterine vessels. Basically, you're stripping away all that surrounding connective tissue to completely isolate the vessels before you apply any thermal energy to seal them off.
Once those vessels are sealed, the surgeons pull off this brilliant little maneuver. They make 2 precise cuts in an inverted V shape, right on the inside of the uterine vessels. When they do that, the vascular pedicle just safely falls out to the side. It's a total game changer. It gives the surgeon this completely avascular, blood-free window straight down to the cervical ring, which massively drops the risk of nicking the ureter since it safely moves away with that pedicle.
Which brings us to section 5, uterus removal and closure. We're shifting from extraction to restoration.
In step 7, the surgeon uses the harmonic scalpel to make a full circle cut around the cup, completely separating the uterus from the vaginal apex. This is what's known as a colpotomy, but you have to be extremely careful here not to accidentally touch the active blade to the metal ring, or you could literally break the device. You might also spot a blue stitch here. That was actually placed way at the start of the surgery to help easily pull the specimen out through the vagina later.
Once the uterus is successfully removed vaginally in step 8, the surgical team runs into a bit of a physics problem. All that abdominal gas they need to see what they're doing, it starts escaping through the open vagina. So they use this incredibly clever, practical hack. They pack a surgical glove with sponges and insert it right into the vagina. It creates an instant, airtight seal to maintain that abdominal pressure, the pneumoperitoneum, so they can finish up the suturing.
Step 9 requires closing the vaginal cuff. The surgeon uses a specialized barbed suture and takes these really deep, full-thickness bites. They have to make sure they grab both the vaginal mucosa and the underlying fascia. This is absolutely essential to securely close up that cuff, effectively sealing off the inside of the surgical site to prevent any chance of a hernia or prolapse later on.
Finally, step 10, the port site closure. The surgeon basically works their way outward. They close the fascia of the larger 12mm incisions with Vicryl suture, close the skin with monocryl, and then use surgical glue like Dermabond to seal up those tiny 5mm incisions. And as a final critical touch, they inject a local anesthetic called Marcaine right into all the incision sites. That way, the patient wakes up with immediately reduced pain.
In our final section, Part 6, Post-op and Expert Tips, a few masterclass secrets for handling complex anatomy.
If you're a medical professional tuning into this explainer, these rapid-fire pro tips from the authors are just absolute gold for avoiding complications. Dealing with a particularly large uterus? Inject dilute vasopressin right off the bat to cut down on bleeding. Got a floppy sigmoid colon blocking your camera view? Just tack it right up to the abdominal wall with a suture. If vascular access is being stubborn, take the vessels higher up first. And, like we mentioned earlier, always respect the fat near the bladder. These little nuances are exactly what separates a standard surgery from a true masterclass.
And that brings us to our final thought. The authors report that for expert laparoscopic surgeons using these exact techniques, the conversion rate to open surgery is a staggering 1 in 400 cases. When you consider that patients can get back to their normal, everyday lives in just 2 to 3 weeks after this highly controlled, minimally invasive approach, compared to the really long, painful recovery of open surgery, we kind of have to ask, with a highly reproducible 10-step method like this out there, how long until the traditional abdominal hysterectomy entirely becomes a relic of the past? It's something to think about. Thanks for joining me for this explainer. Keep questioning and keep learning.